information. Do you have any questions about anything at this point? I'm sorry? Yes. Yeah. Did you just want us to reach out to me? Yes. That's all that we're going to worry about is the TB that most AIDS patients develop. So basically, it's all along the same line, but that's what we're primarily going to focus on. So I know y'all just had a test, and I know that's quite mind-boggling, isn't it? So what I'm going to do first of all, I'm going to show you a couple of videos from Khan Academy. One of them is about what AIDS and HIV is. So y'all can just sit back and relax and just maybe in some information, okay? And note that this video does contain sexual health. Wait until I stick my nose in my mouth. Along the way over the next few days. It's a lot of content. Medicines is probably one of the biggest hurdles that we will have to get over. There's four or five classifications of medications. We'll talk about those tomorrow. We're not going to worry about that today because I feel like that's just a little too intense since you just had your test. So basically we're going to do the videos today. We may do a little role playing today and then just kind of talk in generality about HIV. And then tomorrow we'll really get into what it is, the stages, and all of that good stuff. So, somebody cut the lights off, or is that? Everybody say that? My old eyes.
So this implies that it does something to our immune system somehow, and we'll actually explore that a little bit later on. And if we don't treat HIV, it'll eventually cause AIDS in the infected person, acquired immune deficiency syndrome. So right away, you already get a sense that HIV attacks your immune system so destructively. What is HIV and what is AIDS? Well, let's first look at HIV. HIV is a virus that attacks our immune system. And if we expand this out, we can see that that's reflected in its name, human immunodeficiency virus. So this implies that it does something to our immune system somehow, and we'll actually explore that a little bit later on. And if we don't treat HIV, it'll eventually cause AIDS in the infected person, acquired immune deficiency syndrome. So right away, you already get a sense that HIV attacks your immune system so destructively that you end up acquiring an immune deficiency syndrome. It puts you into a state of immune system failure, so you end up not being able to fight off even the most basic infections. And this immuneless state is what we call AIDS. So let's explore this a little bit further now. Let's actually use the help of a graph. This might be helpful. So here's our graph, and we'll put time down here on our x-axis. And actually, just to make this picture useful, we'll put weeks in this beginning part here, and then we'll transition to years here. And you'll see how this is relevant in a few moments here. So on the y-axis here, we'll put CD4 T lymphocyte count. T lymphocytes are a really, really important type of immune system cell. And CD4 just refers to a type of protein that's stuck through their cell membrane. That's kind of how we like to identify them, by this protein on the membrane. And the reason they get a special spot on the entire axis of our graph here is because they're super important in the progression from HIV infection to AIDS. Because as you might have suspected, it turns out that HIV preferentially loves to infect these CD4 cells of our immune system. And why is it so bad? Well, these CD4 cells, also called helper T cells, play a huge role in signaling your other immune cells to come and destroy any given infectious particle that our body discovers, like maybe strep throat bacteria or flu viruses or even HIV viruses for that matter. So these CD4 cells are kind of central. They're almost like little amplifiers of our immune system. So because HIV loves to infect and kill these cells, it completely disrupts how our immune systems function and renders it essentially useless. So let's say you acquire HIV in your body, either in your bloodstream or your tissues, maybe through unprotected sex with an infected partner. That would be the most common method of becoming infected with HIV in adults at least. What happens? Well, the main thing is that the virus really quickly gets into your white blood cells, so these T helper cells, the CD4 cells we talked about, but also some other white blood cells like your macrophages and so on. And from inside a white blood cell, it can do two things. One, it can sort of hijack your cell's machinery, so it manages to insert its genetic material into your own cell's DNA, and from there it starts to make lots and lots and lots of copies of itself, lots of new HIV particles. Actually, that's really, really important. So let's put that on our graph too. Let's say viral load here on another y-axis here. Viral load referring to the amount of HIV in your bloodstream. So we can see that after our primary infection here, the viral load starts to increase. It's hijacked our T helper cells, and now new HIV particles are being churned out, and our viral load is majorly on the upswing. And you'll notice that the viral load is starting to rise at around the 2 to 3 week mark, and that's just because it takes a bit of time for the HIV virus production to start sort of ramping up within our bodies. And of course, a major concern here as well, the more HIV there is in your bloodstream, the more CD4 cells get infected, get hijacked, right? But the biggest problem here, thing number 2 here, is that HIV infection of your CD4 cells triggers a self-destruct sequence within these cells. So you end up losing these CD4 cells. And even worse, the self-destruct sequence doesn't just destroy the infected cells, it even destroys nearby immune cells that maybe have come into the area to try to help out. So I won't go into the mechanism in this video, but you do end up losing lots more immune cells than just the infected ones. And that's part of why you see this massive drop-off here. This line representing our CD4 T cell numbers has a really steep downward slope. We're losing lots of T cells, while at the same time our HIV viral load is going up and causing more and more infection of our cells. The other thing I want to point out here is you can see this massive rise in viral load and this pretty massive drop in CD4 levels. And this huge viral load means that this time period, right, early on in an infection is when someone with HIV has the highest risk of transmitting it to someone else. I guess one good thing here is that eventually, maybe a month or so in, your immune system gets somewhat of a handle on the virus, and it starts to make anti-HIV antibodies, right? Those are just antibodies against HIV. So they start to fight off the virus to some extent, and this is called seroconversion, when you make antibodies to something. So now we've seroconverted to HIV. So now the antibodies get to work on helping to destroy the viral particles. And that's why we see this decrease here in viral load in the bloodstream, because our immune system is starting to control the viral levels to some degree. And this also gives our CD4 cells a chance to recover to some extent, because there's less virus around to infect them. So you might be wondering how you're going to feel during all this, with this massive battle going on inside your body. Well, you're going to feel sick. You're probably going to feel like you're having the worst flu you've ever had. So about a month or so in that seroconversion, you start to fight the infection. And as a result, most people get some serious flu-like symptoms. So things like headache and fever and sore throat, muscle pains, joint pains. Some people get swollen glands, just sort of fatigue and feeling unwell. Some people get a rash. Some people get some open sores in their mouth. These are some of the more common symptoms of an acute infection with HIV. And this flu-like illness that people experience is referred to as acute HIV syndrome. And the reason for a lot of these symptoms is because, well, when immune system cells get really active, or when they die off, both of which are happening here, of course, they tend to release these little chemical signals that cause inflammation, sort of all throughout your body. And so this is what underlies a lot of these symptoms here. So back to our graph, the immune system can't completely kill off the HIV, even though we have antibodies now, right? And that's because A, remember the rate of immune system killing is roughly matching up with the rate of new viral particles being produced. And B, because the virus has sort of taken up residence in some really, really hard to reach reservoirs within our body, like within the brain and within our bone marrow and within our genital tract. Because of these two reasons, these curves tend to sort of stabilize at some point. They reach a set point where, again, our immune system is killing off HIV at a pretty similar rate to which HIV is replicating. So the curves start to come together a bit more and stabilize somewhat. So this period here is thought of as the start of the second phase of HIV infection, what's called the latency period, or chronic HIV. This acute infection back here being phase 1. So in this latency period, we don't tend to see any clinical signs of HIV illness. The person is often asymptomatic. They're still infectious, but there are few or no symptoms during this phase. And without treatment, this phase will last on average about 10 years. And I said that our curves here stabilized, right? But it turns out that HIV is actually replicating and killing our immune cells just a teensy little bit more than our CD4s are recovering. So over this long period of time, phase 2, eventually, again, without treatment, HIV will start to overwhelm our immune system, and we'll start to see symptoms again. So things like fever or muscle pains or swollen glands, really similar to the acute infection, and again, much for the same reasons as before. And many people at this stage of the illness experience significant weight loss. HIV causes you to use more energy than usual and also prevents you from absorbing nutrients from your food as well as you normally would. So we often see some significant weight loss for these and a few other reasons as well. Eventually, if our CD4 cells get to a critically low number and result in our having no functional immune system, that's what AIDS is. Essentially a state of being where we have no immune system. So at this point, this is when certain bugs, bacteria and viruses that would never stand a chance against even a minimally effective immune system, these things start to infect the person. And we refer to these specific infections as AIDS-defining illnesses because we just know that if somebody has one of these illnesses, they just cannot have a functioning immune system. It just wouldn't happen. Or at least it would be really, really unusual. So there's a high suspicion of this person having AIDS and not just an HIV infection anymore, if they have any of these AIDS-defining illnesses. Two examples of AIDS-defining illnesses are two fungal pneumonias, one called pneumocystis pneumonia and one called cryptococcal pneumonia. These are two common AIDS-defining illnesses. And again, these aren't the types of infections that you get when your immune system works even a little bit. So actually one of two criteria has to be met before we can say someone has AIDS. Either they have to have extremely low amounts of CD4 cells in their blood, and to get a little bit technical here, it's if they have less than 200 CD4 cells per microliter of blood. With the normal count, the normal CD4 count in this amount of blood, it should be around 1,000 to 1,100 CD4 cells. Or, regardless of CD4 count, if they have any of the AIDS-defining illnesses, like either of these, for example, then we can say that they have developed AIDS. And so you might have suspected this, but it's actually the overwhelming impact and the complications of serious infections that you pick up because of the immune deficiency in AIDS that actually results in the death of the person. So from HIV infection to eventually an incredibly high amount of viral particles and low amount of CD4 cells in the bloodstream to development of a completely non-functional immune system in AIDS, very quickly leading to overwhelming infection by essentially every infectious pathogen from A to Z. And because of this, death results. So we know a little bit about HIV now. It's a virus that attacks your immune system, and if untreated, it will cause a state of immune failure, immune deficiency in the person. And that immune deficiency state is referred to as AIDS. It's essentially late stage of an untreated HIV infection. So I just want to talk a little bit about some of the ways that HIV is transmitted, some of the different ways you can possibly get HIV into your bloodstream and thus develop an HIV infection. And let's actually do this in a bit of a simplistic way, because it turns out that HIV is most often transmitted through contact with three different types, I guess, of body fluid from an HIV-infected person. So contact with their blood, with their sexual or genital fluid, and I'll expand on what that means in a minute or so, and from breast milk contact. And let's actually look at this in terms of four fairly common scenarios. These will be the most common situations that HIV is spread via these groups of fluid here. And let me just make it clear that these infected body fluids would need to come into contact with broken skin or directly with your bloodstream, maybe via an injection or something like that. Or they'd have to come into contact with one of your mucous membranes, which are just parts of your body that aren't protected by normal skin. So for example, inside your mouth or inside the vagina or the rectum or at the opening of the penis, HIV can cross into your body through these mucous membranes. You won't just become infected by, say, just looking at these fluids or just being near them or anything like that. One of these fluids would have to make it inside your bloodstream or make it through one of your mucous membranes by physical contact for you to possibly develop an infection, okay? So top left up here, actually the most common way that HIV is spread, typically when having unprotected sexual intercourse with someone who has HIV. And don't let these pictures scare you. These are just cross sections of pelvises. So a female pelvis on the left here and a male pelvis on the right here. So we can use these to look at the sexual organs. So contact with sexual fluids like semen or preseminal fluid or vaginal fluid or even rectal fluid can spread HIV because there's often a fairly high amount of viral particles within these fluids, particularly within the first few weeks of a new HIV infection, when the infected person's viral load in their blood or in their sexual fluids is up at extremely high levels. But in terms of actual sexual activities, in general, unprotected anal sex with either a man or a woman is the highest risk sexual behavior, because not only is there exposure of HIV-infected sexual fluids to mucous membranes, right? The opening at the tip of the penis and the inside of the rectum in a woman or a man are mucous membranes, but if there's any trauma to the involved body parts, there can be some blood there as well, and that might have virus in it and thus increase the risk of infection. Virus from infected sexual fluid or blood can get across the mucous membranes of an uninfected person, or it can just get directly into a person's bloodstream through an area that might be bleeding. Now, this is not to say that unprotected vaginal sex is not risky as well. It turns out that unprotected vaginal sex is the second highest risk sexual behavior. Because again, there's exposure of sexual fluid, right, semen and vaginal fluid, to mucous membranes, which HIV loves to hop across when it can. And again, there could be, although less likely than in anal sex, there could be trauma to the involved body parts. So there can be some blood involved as well, of course, containing HIV. And just so that I'm perfectly clear here, anal sex, I said, had the highest risk of transmission, and vaginal sex the second highest risk. But vaginal sex is the way HIV is transmitted most frequently overall, because overall, more people have vaginal sex over anal sex. And so last in this sexual themed quadrant, I just want to mention that oral sex of any kind, so using the mouth to stimulate the penis, the vagina, or the anus, carries a risk of transmitting HIV for much the same reasons as before. Mucous membranes of the mouth being exposed to sexual fluids, and mucous membranes of the penis or the vagina or the anus being exposed to possibly blood maybe the person's mouth has some open sores in it, which happens to be one of the symptoms that can happen in an HIV infection. And on that note, actually, having untreated sexually transmitted infections like chlamydia or syphilis or herpes vastly increases your risk of transmitting or becoming infected with HIV in risky scenarios, because you're more likely to have breaks in your skin or your mucosal surfaces from symptoms of these STIs, like sores or ulcers. And through these, HIV can more easily infect you. All right, next quadrant here. So after sexual transmission, right, the most frequent mode of transmission, exposure to infected blood. So that's the next most frequent mode of transmission. And in particular, procedures involving needles contaminated by someone else's blood. So, for example, using intravenous drugs and then sharing needles with an HIV-infected person. In that case, HIV is just one of the many viruses you might pick up by sharing needles in IV drug use. Because you're essentially transferring tiny droplets of an infected person's blood directly into your bloodstream on a needle. Other needle-related procedures, needle stick injuries. Let's say you're a healthcare worker and you're working with an HIV-positive patient, right? Maybe you're drawing some blood or something like that. You might accidentally get stuck by the needle after it's been contaminated with their blood. And this does occasionally happen, unfortunately. There's a risk of HIV transmission from them to you there. And remember to keep in mind that risk of transmission depends on some extent to a person's viral load. So these risks are all sort of modified to be higher or lower depending on how much HIV is in a person's blood. Typically very low amounts of HIV if they're being treated with specific medications, and typically pretty high amounts of HIV if they're not being treated. The last thing I'll say here is contaminated blood transfusions. And this isn't so much of an issue these days, at least not in most countries, because of some seriously rigorous screening of donor blood and the blood supply that blood banks have on hand. But back in the olden days, before the sort of late 80s, early 90s, donated blood was not routinely tested for HIV, as crazy as that sounds. So contaminated transfusions don't happen very often these days in most countries, but worth a mention here because it's still something to be aware of. Now, third quadrant, what's the third most frequent route of HIV transmission? Well, it's actually from an HIV-infected mom to her baby during childbirth. And kind of alarmingly, around 90% of the HIV that we see in kids, they actually got it in this way from their mom during their birth, which is also called vertical transmission, mom to child during gestation or during birth. And we're not 100% sure how the transmission happens, but the thought is just because they're being exposed to mom's blood and vaginal fluid on the way out of the birth canal. And because newborn babies are essentially all mucous membrane at birth. They just have really thin skin. So it's not too hard for HIV to jump on board, so to speak. Luckily, there's all sorts of medications that we can give to mom before and after her pregnancy and labor. And there's medication that the baby can take as well. And all of that drastically reduces the risk of mom passing HIV on to her baby from a risk of about 25 to 30% HIV transmission without medication, all the way down to only about 1-2% with medications. So around a 20-fold reduction in mom's chances of passing HIV onto her baby with the proper medication. Now, last quadrant, this one also involves mom and baby. It's transmission of HIV via breastfeeding. Breast milk in an infected mom will contain HIV particles. So when the baby feeds, it'll be ingesting lots and lots of HIV particles, which obviously mom is not intending. And it's not clear how the HIV gets into the breast milk in the first place, but when the baby ingests it, it can infect the baby by being absorbed through the digestive tract. So before we wrap up, I just want to briefly mention two things. So first, the risk of transmission in at least this quadrant here, it goes way down if the infected person is using condoms to sort of physically block HIV transfer, and also properly taking their HIV medication to reduce the viral load in their body, in their blood and the fluids that we mentioned in this scenario here. But also that second one, the properly taking the HIV medication, that will vastly reduce the risk of transmission in needle sharing and in mom to newborn transmission and in breast milk, all of these scenarios here. The second thing is that these are all ways you can contract an HIV infection, but I think it's worth mentioning a few ways you can't contract an HIV infection that might not be well known, or there might be some myths around these. So unless any of these has been contaminated by infected blood, HIV is not transmitted by body fluids like saliva, or tears, or sweat, or urine, or feces. And it is not spread through the air like, say, tuberculosis is. So being around people with HIV won't somehow transmit the virus through the air to cause an infection in another person. And it's not spread from casual contact either, say from shaking hands with or hugging someone who has HIV. It actually doesn't even survive very well outside a human body. So you can't become infected by sharing plates with an infected person at a restaurant or touching a toilet seat at a public restroom or anything like that. But there you go. The main routes of transmission: unprotected sexual activity, contaminated needles from mom to newborn, and via breast milk.
Visual of how the HIV destroys the CD4 cells. So you've got your virus, and then you have your antigen, and then the virus actually invades this antigen, which is also affects will eventually down here affect the nucleus of the DNA. And then the virus has a protein-type coating on it, and it sheds that. And then that allows the RNA to convert to DNA, or to bring the virus into the DNA. And then it starts looking for these cells. And then over here is kind of what happens in the long-term picture. It remains latent, maybe for up to 10 years, I think is what he said. And also, I think that he said that being passed on to newborns or to newborn babies is 1 to 2%. I think your book says 8%. So just bear that in mind. That you may find a little discrepancy like you do whenever you're in clinical and you're looking at your lab values and you're looking at what's in your book. It may not exactly add up because of the difference in the reference ranges that each facility has. They may vary a little bit. So on NCLEX, they're not going to ask you anything that is like borderline. It's going to be either significantly higher or significantly lower, so that you know. Okay? Get you out of that gray area. Does that make sense? So don't worry about that. And then whenever the virus once invades over here, it starts to replicate. And then whenever it starts replicating, it's seeking out other cells. It's looking for other cells to attack. Okay? Does that make sense? So, what does this virus need to survive? It needs a host cell, or host organism. So, if it's got to have something to live on, just like he said, you're not going to pick it up off of surfaces or air or anything like that. So, this docking of the protein outside of the virus has to find certain special receptors to hook up with on the host cell for the virus to actually bind to the cell and then to get inside the cell. And there's well, we're worried about the GP protein and all of it. That's a whole different story, and that's not really how it focus on to take care of your patients. So the virus has to get the DNA material into the nucleus of these CD4 and the T cells, to place it in the human DNA. Does that make sense? So the cells have this DNA, the humans have their DNA, and it has to convert for HIV to do that. Everyone with person can have HIV that has not progressed to AIDS, and we'll talk more about that when we get into the stages, because that's your defining characteristics of what stage they're in, and is they're actually have progressed to AIDS. Okay. You said that your normal cells count CD4 count is what, 1,000 to 1,100. I think that your upset's around 800 to 1,000. So there again, you're going to find a little variation in the range. Don't worry about that. Just know that it's going to be within those numbers in a facility. See something out of the ordinary. 50 to 90% of the people who were first infected develop an infection within the first week or so of being infected with the HIV virus. And you can continue to have a cell count to go down, but the patient is looking better. But what's happening is that your cells are not functioning properly. They're functioning very poorly. Okay. A couple of other things that I wanted to mention with this is lymphocytopenia is something that you see fairly common with these patients. Does anybody remember what that is?
Decrease in lymphocytes.
Well, how is that going to, when you think about what the lymphocyte cells do, how is that going to be presented in a patient? What type of side effects are you going to see in your patient with this if you're examining them? What might you see? Because think about the lymph nodes. You're going to see enlarged lymph nodes because your lymphocyte count is down. They may have a cough, they may have a runny nose, things that's very similar to a respiratory virus. They may also have some skin issues like eczema. They may have alopecia. You remember what alopecia is?
Hair loss.
Hair loss. Okay. And they can also progress to having hemorrhagic conditions. They can be pallor, they can have petechiae, or the hemorrhagic areas of their skin. They can be jaundice. They can also have mouth ulcers. And we're going to talk more about that and candida, which is very common with AIDS patients a little bit later, and how we're going to take care of these patients. And also another thing that happens is your macrophages. Now, remember what they do? They're the little soldiers. They go in and eat everything up that's bad, that shouldn't be there. So you also have a malfunction in those particular cells too. So whenever it's exposed to this inflammatory response that's created by the invasion of the HIV virus, they tend to stimulate a secretion that's called cytokine that is almost like a tumor necrotizing type substance that tries to attack those cells.
You said so you have like necrotic.
Well, the macrophages are like the soldiers, right? So they go into your skin, and basically what happens whenever you have an inflammatory response, they realize this, so they are trying to attack these cells, and the cytokine is released in effort to try to fight those cells.
The infections. The infections.
Yeah, the ones that are affected by the HIV. So we've already talked about how AIDS can progress, HIV can progress to AIDS. Let's talk a little bit about the etiology. It's kind of like a parasite. That's basically what AIDS is, and it's looking for a way to take over your cells. So it is wanting to force the virus to make copies of the cells, just like we talked about earlier, that it's seeking to invade the good cells. Now, the retrovirus is the family that it belongs to. Okay. Do you remember what opportunistic infections are?
Yes.
What's an opportunistic infection? It's what you have in your body. It comes from you. Is that contagious?
No.
No, it isn't because it's yours. Yay. Okay. Typically, whenever you have an HIV from a patient that has progressed to AIDS, if their cell count is below 200, that's typically when you're going to see the infections. And you're going to have patients that come to the emergency room, maybe they have never been diagnosed with it, but they come in, they're very emaciated, very pale, they've been sick for a long time, they haven't sought medical treatment, and that may be what their underlying problem is. Because they have never been diagnosed with it. And then once a person has HIV, they never revert back to not having it. And by the way, that clock up there is not right again. I noticed at 10:20 that it didn't move. So we'll keep an eye on the time, so make sure you're kept on schedule. So, not sure what's going on up there, but anyway. Okay, so let's talk a little bit. Tell you what, let's do before we move on. Let's do this. This work has a profound effect on a person's psychosocial being. So let's do a little bit of role play. Who wants to have AIDS? Okay, I'm going to elect somebody. Okay. Okay. Who wants to have a part? Do a part? Okay. Another part? And okay. And okay, so let's have our little AIDS patient in here. And I'll try to give you some different scenarios so that when you're caring for one, you are very well aware of how this is affecting them psychosocially. Because a lot of times, and even the public is very poorly educated on this sometimes, okay? And they feel like it's like a taboo. It's not going to hurt you if you touch the patient. Okay, you'll have to stick with the rest of you. Okay, let's do this one first. You just want to go ahead and tell us a little bit about your background and what you're supposed to be doing. The main thing I want them to see is the interaction. I don't care if you're a hairdresser or if you're
Airplane pilot. Okay, so we're aboard an airplane and she is the host. What do they call the people?
Stewardess.
Flight attendant. And I'm another flight attendant. I walk up and I see her sewing. You're kidding, right? I'm going to call the CEO and get you fired. You don't need to be working here with AIDS. You can infect people. And then I walk off and get the CEO.
So, now, how did you feel about that?
I felt like she cut me out.
That was rude.
And you know, but never in the years of this either in an environment like that. How did she find out that you had AIDS other than your son? How did she find it out? Was there a HIPAA violation somewhere along the way? Is it true? It might not even be true.
I think it wasn't her CEO's business.
Could have.
They're very educated.
She could be. Like we said before, a lot of times the public is very poorly educated on things like this, and we tend to jump to conclusions about caring for people who are HIV positive or have AIDS. Okay. What else? Anything else? Anything else that you felt did make you mad? Where is the next one? You're just counting stuff.
Oh, you must be one of those
Okay, now look at the different. Stereotypical. What else? Anything else? Why did you assume that she was homosexual for her? Okay, because she has AIDS. Maybe she got it through a blood transfusion. We don't know that, do we? So we have to be very careful. Why? What is blocking her up to deal with the situation? How's that going to help her? She won't spread it. Okay. What about the people she's locked up with? They don't get it. You're going to make sure of that, right? Share love. Okay. Who else has one? Okay.
Gosh.
She's already
I'm offended too.
So nice to meet. So she was a friend of a friend, and I was being introduced to her at a social function, and then I realized who she was, and so I refused to shake her hand. Walked off and asked my parents for instructions to watch them. That's rude.
And these patients do take care of them in the hospital. A lot of times they do feel very isolated and left out because they don't have a lot of human contact sometimes, but it's very important. One more. Bring it over. Nice to meet you. What was the difference?
She had a bigger piece of paper.
She had the bigger piece of paper with the smallest words on it. Use words on it.
What did you say?
Yeah. So, but did you see how the difference is in telling her being respected? She wasn't scared of her. She was okay to sit with her. She was okay to shake her hand. Okay? So hopefully things like this will help you remember how to check the test about transmission and how it's transmitted and things like that. So just kind of a little bit, I'm more of a visual person than some people are. I don't know. I'm wondering why they're laughing.
Plot twist, they both have age, that's all.
And how is that making you feel?
They both have it.
Right, so what are some things that we can do for this patient to help them in these situations? Think about some things that we have access to in the hospital or in the community. What are some things that we can put them in touch with?
Support groups. Support groups or community-based resources to involve them to prevent isolation.
Community awareness.
Where there's other people that have the same conditions that they do, putting their family members in touch with groups maybe that have other family members that have the same issues going on, so that they can have a better understanding. Okay, so let's move on now to our stages. Okay, so this is the classification of it. This is basically how patients are classified in the hospital. Tomorrow we'll talk about the medicine. Medicine is probably going to be one of the hardest things to kind of put together, but your book has a very good diagram on 328 about what medicine affects what part of the cell cycle. So we'll talk about that tomorrow. And I think if you can use this visual, that will help make it a lot clearer. They never ever use just one medication. They always use more than one medication. It's never just a monocourse. It's usually more than one, because there's different areas of the cell that need to be affected. But we'll talk about all of that tomorrow. Okay, if you're looking at stage 1, know that the patient has HIV. We know that that's been confirmed with blood tests. And we'll talk more about the blood tests tomorrow too. And you're looking for a cell count of greater than 500. And also, they do not have any AIDS-defining illnesses. You remember he talked about those? We're going to talk about probably about 4 or 5 of those that are the major ones that will cause patients the most problems and that you'll probably see the most in the clinical setting. So we'll talk about those tomorrow whenever we start pulling it all together. You have stage 2. They're also confirmed, but their cell count is low. So they're really, right at this point, they're getting on the borderline of developing some other AIDS-defined illnesses, infections. They can have 2 infections at one time, too. So just because they have the pneumonia doesn't mean that they can't have histoplasmosis, too. So they can have several things going on at the same time. Then we are looking at stage 3. This is when you start having your AIDS-defined illnesses and your cell count is below 200. Okay. And then when you get to stage 4, this is where they have it, but you do not have any information regarding their cell count. Has it been up? Has it been down? Tomorrow we're also going to talk about the cost of some of those medications because they're very expensive. And when you have to take multiple medications, it adds up. So we're going to talk a little bit about that tomorrow too. And in stage 4, this is where you have the people that come in that are, they have the pneumonia or they have toxoplasmosis, whatever, as far as one of the AIDS-defining illnesses. And we didn't know. We have no records to look back to see. Well, 6 months ago, their cell count was over 500, and now it's below 200. So, who do you think is the most affected by AIDS as far as treatment? What group of people?
Low SES.
Males, as far as the treatment. And who has the poorest outcome? Women. You're right. Women does. Do you have any idea why? Well, a lot of times we are the caregivers. So we don't acknowledge that we're not feeling well, or we don't take time to acknowledge that we're not feeling well, or that we have things going on with ourselves. And it's overlooked to the point that it becomes a big issue, and it's very difficult to treat at that point. You have AIDS-defining conditions 329 in your book. You may want to take a look at that. That just gives you some of the disease processes, but there's lots more that certainly gives you a good idea of where we're headed with all of that. Now, do you remember? Your cell count can go up, but once you have it, and most of the time these patients, they're very, very sick. They're very wasted. They're sick. They just look chronically ill, like little COPDers, that have been smoking for 50 years, and then finally one thing happens that pushes them over the edge, and they weigh 100 pounds soaking wet.
I have an HIV patient, and you were talking about affected families. Her daughter, I think, was 17, and she said that her daughter would give her her medicine every day, but she had no idea that she had it.
And that's a good point ethically too. You're going to run into these situations in the hospital where the patient says, "My family does not know this, and I don't want them to know this." So then it becomes your responsibility to come up with some critical thinking skills to how to dance around that, because the family's going to say, "Well, my brother has been here for 2 days and he's not any better. Why is he not any better?" are you going to say? That's exactly what you're going to say. What are you going to say? I'll pass your concern on to the doctor. You know, and it may be a situation that they may need to change some antibiotics around to get some improvement in his condition.
Want their information out to me.
They do, because you're going to be dealing with families, and they're going to be all over you. You can't just read it. Well, I think that's going to throw up a red flag for them immediately, if they don't already know. And sometimes I think families know, but as long as they don't acknowledge it, it doesn't exist. You know, there's a lot of people like that. You know, if you don't acknowledge a problem, it doesn't exist. That's not true, as we know. So it may be that you need to refer them to the doctor. You may need to refer them to the patient. You know, maybe you need to talk to your brother about this. And just let the patient know that, you know, they're asking a lot of questions, and a lot of times they don't understand the fact that the family is just concerned about them. It's not that they're trying to meddle in their business or be nosy or anything like that. It's just that they're concerned about them and what's going to happen to them whenever they're discharged from the hospital. So sometimes you have to kind of point that out to the patient, like, you know, I really think that they're trying to just focus on you and what's wrong and try to help you get better and look at resources that will be available to you whenever you get out of the hospital. Sometimes you have to just point those out to them, and sometimes that helps, and sometimes it doesn't. They're still very adamant, and that's their right. If they choose not to share it, then that's their choice. Okay, servo conversion. You remember what he told us about servo conversion?
Oh, I think it's 0.
I think your book says now, what are the characteristics of this? What's happening in this phase? Right where the word is. It's developing, isn't it? So do you remember the time frame that this usually occurs?
A month.
Usually it will occur anywhere, and this varies from individual to individual, 5 days to 3 months. Usually you're going to see the highest incidence 1 to 2 weeks. So that's when they're going to start developing those flu-like symptoms. Their viral load may be down. And the body doesn't necessarily acknowledge that this is HIV. It just acknowledges an inflammatory response is going on, and that's how it responds. Does that make sense? Yes?
Yes.
So it doesn't necessarily matter about the amount of exposure that you have. Well, of course, I mean, you know, if you're exposed 20 times as opposed to 1, you're going to develop a higher risk. But the thing that tends to matter the most is how your body responds to that. Okay. How is it responding to the inflammation? How's your immune system responding? So, if you have a patient that is on chemotherapy, how do you think they're going to respond to it?
Their immune system's already compromised.
Damaged, so they're going to be much more likely to develop some of these age-defining illnesses as opposed to somebody that doesn't. What about somebody that has taken corticosteroids?
Decreased immune system as well.
You're going to have decreased immune system as well. So you may have some more effects with them. So some of the early symptoms that you're going to see with this is your CD4 count is going to be less than 500. And think about, when you think about a virus, just think about the things that goes along with the virus when you have a virus. You have flu-like symptoms, your muscles hurt, you have a fever. These patients have night sweats, particularly if they have TB. But we'll talk about that next week. They may have diarrhea. They may have a lot of diarrhea, maybe from family. So what's going to come into play there? What kind of problems do you anticipate with that?
Dehydration.
Dehydration, that's a big complication with these patients. They're going to be very tired. There's the lymphadenopathy that they have, the swollen lymph glands, it's going to be painful. They actually affect their ADLs. They may not be able to perform their ADLs like they did before, so they may need some help with that. They may have a problem with recurrent infections. And just because you have an infection one time doesn't mean that you can't get it again. A lot of times it may not be as severe, that you can still get it again, especially if you're in a compromised position. And you can also have some neurological effects, which are going to, you can have numbness and tingling in your extremities. What things do you think affects the outcome of treatment? What are some things that you can think of? Compliance. And I will tell you that these patients, it's not like taking an aspirin every morning. I mean, they have several doses a day of medication that they have to take. And compliance can be a very big issue. And then whenever you throw in the financial issues too, if we're not able to get funding for that, then that can also be a factor. What about education or lack of knowledge to know how important it is for me to take my medicine every day? Because if I skip just one dose, that can give my cells a chance for that virus to invade. So that's not something that you want to do. So let's say that your patient's going to be, let's say he's going out of town to a wedding, and he wants to know if it's okay if he just doesn't take his medicine during the time frame that he's going to be gone. Does that make sense? Okay, like if he's going to be out of town at 2 o'clock in the afternoon, and he normally has doses due, and he says, is it okay if I just skip those doses? No, it isn't okay. Just skip those doses. Because you're opening up the door for that virus to invade more cells, and you don't want that to happen. Socioeconomical status, which is basically what we just talked about, and then just the lack of adequate care, because if you have patients that they have families that have to work, or they have young children that are in school who have no concept of how to care for them, then it's more likely that they're not going to get the quality of care that they really need in their home, unless they can get some type of, if they're fortunate enough to have some type of in-home insurance, or if they can get on one of the Medicaid or the CAP programs. And usually there's a waiting list. That's not something that just happens like that, so you normally have to wait a little while to get all of those papers and everything in order. So it can be quite a challenge. Typically, insurance is not going to cover in-home care. A lot of people think that, oh, I have insurance, it'll cover it. It doesn't. Whenever you start really looking at the policy and researching it out, 99% of the time it doesn't. So, you know, they've been disillusioned about that because they thought it did. And now they find out, I don't even have any insurance. I can't work because I'm not able. What am I going to do? So that can be a burden on the patient as well as the family. Okay, what questions do y'all have? Do y'all have any questions so far? I'm sorry. 99% of the time, insurance is not going to cover it. People think that they have insurance to cover in-home care so they can stay home, but when you get right down to it, they don't. So be very careful whenever they think that they have the insurance coverage. A lot of times they don't.
So, let's say, you're in one occasion, is it likely to eventually get AIDS, or the medications actually enter on?
That's individual. It depends on your body's response, your body's immune response. So hopefully, if you take the medications and are compliant and do what you need to do, then hopefully to the AIDS stain. But then again, it's AIDS. But it all depends on your immune system and how strong it is and how it responds. I did do a little bit of statistics from the CDC. Your book has information, I think, from like 2013. But in 2015, there was an estimated 39,000 people in the United States that were diagnosed with the virus that progressed to AIDS, HIV virus. 1 in 8 people don't know that they even have HIV. So I thought that was a little interesting. So, over 39,000 people in 2015 was diagnosed with HIV, and 1 in 8 people don't even know that they're infected with it. So what's the moral of that story?
Abstinence is best.
Now, in the United States, there's like 36 million, or in the world, there's like 36,900,000 people that have it. But that's worldwide, not just in the United States, that's everywhere. 36 million, over 36 million. That's a lot. And about 1.2 million of those people will die, or did die in 2014 from AIDS-related illnesses, things that you just can't control. Let's talk a little bit. We've already talked a little bit about the incidence of prevalence. We've already talked about what class of people it is most common in.
Women.
Do you remember what he told you on the video too, and what your book says? Men having sex with men. Okay? You're just waiting for me to run that out. Okay, so now moving on. All right, why do you think that is? Why do you think that this particular group of people run a higher risk?
Sexual habits.
The anal sex.
Anal sex.
In the video.
Well, and the tissue. Think about the tissue, the mucous membranes. Think about how thin and fragile they are.
The blood vessels is superficial.
That's right.
That's the second time in 2 days you used that.
It's like
When in doubt, say superficial veins.
For IV drug use, it can be either one, and it's about 16% of the population that are HIV positive have acquired it from drugs. And we'll talk a little bit more about that and how you can use reach around with use to sterilize your needle and all this stuff. Really do that. It doesn't happen in the real world. We'll talk about that tomorrow. And so just remember that this is not necessarily just a problem for homosexuals. It can be any class of people, okay? Do you have any idea what ethnic groups are having an increased trend? And I'm not going to ask you this on a test. That doesn't make any difference about trying to take care of an AIDS patient. I mean, but it's something good for you to just to know in general, so that when you have patients in the hospital and trying to pinpoint a problem that might ring bells for you. So African Americans, Hispanics, and then of course women we talked about having the poorest outcomes, and of course the largest risk is sexual exposure. Okay, are we good on that? So, you know, we talk about the health promotion and maintenance. We talked about all of the, we talked about all of the body fluids. So let's take a look at those, because I want to make sure that we have all of those covered, because there's lots of them. So let's see. We got blood, semen, what else?
Yeah, I thought it said no to urine.
Unless it's in contact with blood.
If there's
Unless there's blood in
There's a
it.
trace of blood in it. Yeah. What about saliva?
He said no.
It's from the membrane. So then we should just say
Bear that in mind. What about cerebral spinal fluid? Yes. What about lymph nodes? Remember, we talked about the lymph nodes being enlarged in inside of lymph nodes, it can also be detected there. What about corneal tissue? Your eyes, and then brain. So we've already talked about the ways that it can be transmitted. So what's the four main ways that it can be transmitted?
Sexually.
Which is the most prevalent.
IV drug use.
What are the ABCs of that? You know, A is for abstinence, B is to be faithful, and C is to use condoms. That helps you remember that. Be faithful.
Caution.
So typically what happens here is you have infected males who infect females. That's basically what a lot of the times that's how that is transferred because of the large amount of vaginal tissue. Does that make sense? What other methods do we have of transmission? IV drug use. What else? Breastfeeding, perinatal, prenatal. Just perinatal.
sticking the throw on.
I'm not a big person.
What did you?
Not at all. So, it can be transmitted through the birthing process. Anything else that you can think of?
Sharing needles.
Sharing needles. Okay. So if we're looking at the parental transmission, what would be some things that we could do to prevent that with needles? If we were educating the community, if we had to do an education project. Don't reuse them.
Clean needles first with fair water, then bleach.
Yeah. Yeah. And like everybody carries bleach in their car, right? That doesn't happen either. That doesn't happen in the real world. So needle exchange programs. Do y'all have one here in Cabarrus County? Don't I? Okay.
Not my area of use.
It's a program that they can go and switch out their needles. They can switch out the dirty ones for the clean ones. It's kind of like, are y'all familiar with the methadone clinic? You know those kind of about that. Well, it's kind of like that.
They're going to use it when they keep them safe.
Since 1985, there's been a lot better screening of blood products, so you don't have to worry as much. We also do what is called a autologous transfusions. Do you have any idea what that is? Their own blood. If they're going to be having a procedure that might bleed a lot, like maybe a total hip or some type of abdominal surgery, if they're physically in the condition that they can donate blood before, like if they have time to 6 to 8 weeks before, then they can go into the hospital and donate their own blood, and it will be safe to use during their procedure. So that kind of helps limit their exposure. And then of course, there's all kinds of substance abuse
drugs, which Carrie Ann will also help educate the patient on the disease and things that they can do to protect themselves. You've already talked a little bit about crossing the placenta. Medications can be used, but they are usually started after week 14 of pregnancy, and you don't want to start them after week 28 because of the damage to the fetus. This can be good because our food didn't have that in it. These big routes. Well, your book said, the maternity book said that it was taken after 14 weeks and stopped after 28 weeks. So,
The ZDB?
probably why he's probably more up to date than what your book is. So, and does everybody have edition 8? Because I know last year somehow some ended up with 7, some ended up with 8.
What? Which book? The maternal? I have 7.
Okay, so what's something else? If the infant would pick it up in the birth canal, what might be something else that could be done? C-sections to avoid the contamination of that tissue. Okay. All right, what about healthcare workers? What do you think is the #1 way that it gets transmitted?
Needle.
Accident.
How many have you have been stuck with needles? We probably all have it somewhere or another. I had a student last semester in the second year. Her patient was very thin, and she picked up his skin to give him an insulin injection, and it went through his skin. Stuck her finger on the backside. She was safe. We did all our testing and everything that we needed to do, but little things like that you just don't think about. But he was just, his skin was very thin and he was very tiny, and she pinched it up and it went through. So, bear that in mind. Well, and realistically, probably if she had pinched a bigger chunk, it probably wouldn't have happened. Lesson learned. Okay, blood and body fluids. What type of precautions do we want to put these patients on? Standard precautions. Okay, and that's what you want to use with everybody because you don't know. I don't know if you have AIDS, you're not going to have to take care of you in the morning. So if we observe those standard precautions, it's going to be much safer for us and for the patient. So what do you want to do if you have any blood or urine spills? You want to make sure you've got your PPE on, right? And you want to make sure that anybody else, that housekeeping is coming in. You want to let them know that, hey, this area is contaminated so that they don't potentially get exposed to it as well. What else? You don't have any questions about that? Okay. We're going to talk about progression of it, and then I think we're going to stop there. I think that'll be a good stopping place. I feel like y'all talking about issues. Pick up tomorrow. Tomorrow we'll talk about the medications, and we're going to talk about some of the AIDS-related illnesses that occurs with these patients. Progression of AIDS. How long can it take for AIDS to progress? Years, months to years, depending on the person's body's response to the previous response. And it may depend on how it was acquired. So, if it was just by casual sexual encounter, then it may not be as likely to get it as blood transfusion, because it's going right into that person's circulatory system. Frequency of re-exposure.
So you have people who have a lot of recreational activity. They may be more inclined to get it than somebody who doesn't. So, STDs, if they've had a lot of STDs in the past, or things like that, if they've been to the emergency room to get their injections, or they've been to the health department to get injections, whatever, antibiotic injections for those, then that may be a good indicator if they tell you in their history, oh yes, I've had gonorrhea 3 times. It's like, what have you been doing? I don't want to know, but you question in your mind what's going on. What about the nutritional status? What do you think about that? How does that come into play?
The healthier you are, the less likely it is to like
Well, yeah, and you're not going to be able to fight it off as well. You're not going to be able to maintain your weight because the muscles are going to waste. And you have your protein and albumin, which keeps your fluid inside the cells. And then when you lose this protein and albumin, which is what happens in the malnourished state, you lose the ability to keep the fluid inside your cells. So what happens is it leaks out and you may see jerk space shifting. You see this a lot of times in critically ill patients because they have lost that protein and albumin because they're not able to eat and the caloric demand is so high that there's just virtually no way to lose weight. What about stress? What do you think about stress? Do you think that can have an impact on it too? Right. It can affect your immune system, your ability to fight off infections, your body's response to infections. Y'all have any